exposed in 95% of the cases by HSP1.
What percent HSP1? Is it possible for the non-invasive method to pinpoint HSP1 yet?
Sir, we can do DNA PCR. By PCR method we can find out. Because the DNA characteristic of both biopsies are different. No, we were not able to do, because we did the CSF before the MRI came, and we did not preserve any sample. And after that MRI was so characteristic, we did not go for any test. Yes. Sir, here we see these are the areas of hyperintensity. The medial temporal lobe involvement, this is very characteristic of Hashmi section. These are usually unilateral, but in this case we found a bilateral anomaly.
Previous.
Here the frontal lesions are also involved. He had extensive lesions.
We had got another patient, TT was there. He responded very nicely. He was an alcoholic. Same thing was that. He responded, he came to us after 24 hours. 24 hours.
Second bed.
So 24 so gave him medicine empirically. Within 7 days, patient responded.
That patient. That
That
patient.
patient taken
That patient we were able to discharge it within 10
hours. Patient came to us, who is treated patient. He responded very nicely. He went back and he is coming for the hospital.
He had no sequel.
No.
He has no sequel.
Another patient is female ward.
Yes,
The patient is admitted with a fever. The lady, what is that?
Ricardo, at the age of 37
years.
she
Fever,
presented
sensorium and seizure.
seizure listed only. When we are present, she developed seizure in our hand. And she came with fever of 7 to 8 days, then altered sensorium, restlessness, and mild meningeal signs, neck rigidity, plantar and downward. And on that day, on 6th of this month, she became restless. So we had to put a diagnosis. And CT scan was done on that day, diffuse cerebral edema. On the same night, CT scan was done. And on the same day, we started acyclovir and monitor. Of course, we had, this patient was very serious, so we have started methyl prednisone.
So treat the LP also. LP is also the viral.
It is viral. Total count is 400 and lymphocytic myelocitosis. And protein is 2.3 gram per liter. And sugar 44 and ADA negative.
Acyclovir period, how much days you should give?
So now it is recommended for 14 to 21 days.
Minimum 14 days, not less
21
than
days.
14. And this by temporal hemorrhage due to temporal hyperintensity due to the hemorrhage in that locality.
Yes.
And the RBC in the CSF is due to this.
In my experience in this hospital, at present I am having one patient. We should be very cautious for giving this acyclovir because that patient has landed up into acute renal failure. So that should be kept in mind.
Proper dilution.
Proper dilution.
We are having another patient in Male.
Male.
He had acyclovir-induced renal failure. We
ARF.
gave him 3 stocks of hemodialysis, and after that he has recovered.
That should be kept in mind.
Initial hydration is very important.
Very important. Number one. And number two, in case of HIV, particularly immunosuppressed patients, they may be resistant to the acyclovir. And at that time, foscarnet is the drug of choice. Number one. And number two, if the patient is not responding to foscarnet, then we can use the latest drug, that is biradavir. That is also have a very good CSF penetration. So So acyclovir in that particular immunosuppressed patient, foscarnet is the choice. Second drug is vidral.
Actually, sir, the concentration of acyclovir, it should be less than 7 milligram per ml.
So it should be
Diluted with 100
diluted properly and proper
slowly,
hydration.
slow infusion and slow infusion and renal parameters to be assessed.
In society, so many encephalitis remains undiagnosed. Basically, clinical practice, it is a very commonly found, and it is sometimes DD only, differential diagnosis and pinpoint is a very one. Encephalitis, meningitis, encephalomeningitis, very common and very commonly, every day in papers. Japanese encephalitis, one of the killer disease in young boys, particularly 5 to 15, even in the eastern part of the Gorakhpur, near that area, Muzaffarpur last year also, this session also, more than 85 children have died encephalitis. Even in
Japanese
Kuch
beer,
Bihar,
Nipah virus
Nipah virus encephalitis in Kuch Bihar last session in Calcutta also, so many from the Kuch Bihar area have been shifted to patient. So sometimes unknown virus, particularly arbovirus. Arbovirus is a huge challenge for India. And arbovirus, this encephalitis, we are always keeping in differential diagnosis, and luckily nowadays from LP after MRI, the diagnosis is somewhat clear. Otherwise, what in traditionally teaching was Gherao therapy. Was saying, you have to cover falciparum, you have to cover higher antibiotic, you have to cover antiviral. And that is the method to save, otherwise we are going to lose the patient. So third option was antiviral. Nowadays MRI has given some clear-cut pictures. That's why we are able to pinpoint the HSP. Otherwise we have to very
I want to stress is that whenever we are suspecting HSV, one should
treated
start the
empirical
antibiotic
at the earliest.
Empirically earliest.
Because our limited resource of investigation
Yes.
constant is there, so we treat it with the benefit of doubt. And person responds also. Most of the person responds.
Within 48 hours. Within 48 hours.
Eliminating viral falciparum malaria and
Yeah.
enteric encephalopathy, one
Yes.
should start.
That's our teacher used to say this Gherao.
Gherao.
You have to keep it, otherwise patient is going to lose within 48 hours.
Madam, one question I have. Is there any role of steroid to prevent sequelae?
No, it is not sequelae, prevention of sequelae, but it is the initial part, initial immune response.
Inflammation.
Which may be responsible for the cell damage, partially for the cell damage.
Will it
but
affect the sequelae in any way?
that is actually under trial. It has not been studied. The amount of cellular damage may be limited by the role of steroids, but the steroid has a harmful effect because it will suppress the host cell immunity also. It suppresses the viral replication. So it is not at all recommended till now. The studies are going on, and until the results come, it is better not to use.
So within 48 hours of admission or within 48 hours of onset? Treatment.
Treatment
Treatment
within
is
48 hours of onset.
Whether patient is admitted within 48 hours.
This patient was admitted to our hospital after 5 days. He was initially treated elsewhere with
Challenge study.
hepatic encephalopathy.
Steroid along with the acyclovir.
They thought to be hepatic encephalopathy and was treated in that time. We started him on acyclovir on the day of admission.
Crystallizes. If hemoconcentration is there, if patient is dehydrated, then there is more chance. So if patient has to be hydrated
Still also it occurs. Acyclovir occurs.
and to be given slow infusion.